بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. وبداية نتقدم بخالص الشكر والتقدير للإخوة الأعزاء الأستاذ الدكتور عباس عرابي والأستاذ الدكتور علي عبد الرحيم على الدعوة الكريمة للمشاركة في هذا المؤتمر الممتاز. أنا أحب المشاركة في مؤتمرات الدكتور عباس والدكتور علي. الحقيقة يعني هم محترفين، أولاد كار سموهم، يعني باستمرار في أفكار جديدة وفي أبروتشز جديدة، وأنا يعني سعيد بلقائي معهم باستمرار. وبعدين بنلتقي في مؤتمراتهم بالأشقاء من الدول العربية، وده أيضا بيسعدنا لأنه يعني إحنا مش بنشوفهم كتير، ما حدش بيشوف حد كتير دلوقتي، فالحقيقة بننتهز هذه الفرصة أيضا. فالشكر والتقدير موصول لهم إن شاء الله، ويعني أدعو لهم بالتوفيق إن شاء الله باستمرار. هم طلبوا أتكلم عن risks of Ramadan fasting in diabetic patients. This is a very basic issue, a very important issue regarding Ramadan fasting, because please always remember that Muslims do not fast to get health benefits. Of course, it is not mentioned. Health benefits على فكرة بتاعة الفاستنج ما هيش مذكورة. أنا عارف إنه في أخ عزيز هيتكلم عن الهيلث بينيفيتس، أنا بس عايز أتكلم عن حاجة من ناحية شرعية مش من ناحية طبية. الحقيقة إن الهيلث بينيفيتس مش مذكورة أبدا، لا في حديث ولا في آيات قرآنية القرآنية. لعلكم تتقون مذكورة التقوى والمغفرة والرغبة في رحمة ربنا سبحانه وتعالى ودخول الجنة وكذا، لكن ما فيش حاجة عن الهيلث بنفيت. في حديث اسمه صوموا تصحوا أو جوعوا تصحوا، وهذا حديث ضعيف لا أصل له. أنا بحثت عنه ولم أجد له أصلا، وبالتالي إحنا كأطباء دخلنا قصة الصوم من منطلق the potential harm which might result for those patients who are not fully healthy and who want to fast Ramadan. فإحنا داخلين لنتجنب بشكل أساسي لنتجنب الضرر المحتمل الذي يمكن أن يقع على المريض. وطبعا البنفيت اللي موجود اتس بونس، يعني لابد ان طبعا في بعض الفوائد الثابته عند بعض الناس، لكن the basic issue behind fasting Ramadan, behind our intervention, we had been invited actually to share the issue of Ramadan fasting in diabetic patients from the door of the disease, from diabetes rather than from anything else. Because of that, it's very important for us to study very well and to know everything about the risks of Ramadan fasting in diabetic patients. Well, there's always a need for effective guidance on the management in diabetes of Ramadan. Expert opinion is important, but randomized control trials are needed. احنا دايما محتاجين randomized control study. للأسف after all the efforts which was done in Ramadan during the last couple of decades, we're still lacking a full set of randomized control studies which can give us a clear benefit. So most of the recommendations in different guidelines are based on consensus expert opinion more than the controlled clinical trials. Definitely, the controlled clinical trials are progressing. However, the basic issue or the basic support of the recommendations and guidance is currently coming from consensus expert opinion rather than anything else. The prevalence of diabetes in Muslim population is rising more quickly than the average rising of diabetes in the whole world. So the Muslim population is increasing in general, more than the average population of the world, and consequently, those patients with diabetes are increasing as well, much quicker than the rest of the world. And a significant proportion of Muslims fast during Ramadan. And there are many studies, actually, the Creed studies, one important to them. It was found that it's 94% fasted more than 15 days, and 63 fasted every day, and this is among diabetic population. So Muslims love fasting. Sometimes they can, neglect regarding other Islamic recommendations. Sometimes they do not. They are not very adherent to all the recommendations. But when Ramadan comes, overwhelming majority of Muslims prepare themselves and start fasting and start observing other recommendations of Islam at the same time. Fast can have adverse. This is the topic of this presentation. Fasting can have adverse effects on glucose homeostasis, leading to complications. Ramadan fasting is associated with significant lifestyle change. All of us know that very much, the change which happens during Ramadan. I'll come to that in a minute. These changes can impact on an individual's metabolic status in healthy individuals. And this impact on the individual's metabolic status is important, of course, in healthy individuals, but it is especially important in presence of diabetes, because the metabolic status is already compromised and affected. There are multiple factors influence the risk of Ramadan fasting in an individual with diabetes. These risks, we can summarize the risk factors which will affect people with diabetes. The type of diabetes, type 1 is different from type 2, of course. The level of glycemic control is very important. Those who are entering Ramadan with controlled diabetes are less likely to develop complications, of course. The medications used, and this is an important point again, because now we are more and more having drugs which do not affect the fasting status in a very significant way, or they can help patients to fast more safely than old agents. Of course, the price factor is important, but it's very important actually to have tools in our hands which can help Muslims to fast safely. Presence of comorbidities, of course. A patient with diabetes, if he has or she has cardiovascular disease, for example, diabetic decompensation, complications of the kidney, large vessels, small vessels, microvascular, all that will affect definitely the risk which will happen to the patients and the personal circumstances. People are not similar to each other, depending on their age, on their type of work, on the climate where they live, the length of the day and night. The circumstances around the patient definitely are important in determining. So these are the factors which will determine how risky a patient is who he wants to fast Ramadan. Now let's have a look to the adverse glycemic events. Of course, risks are not only due to glycemia, but to other risk factors. I don't know if I'll have time to discuss some of these risk factors apart from glycemia or not, but let me proceed and see how far can I reach. Adverse glycemic events have been reported in observational studies during Ramadan. EPDR study, which included more than 12,000 patients and published in the year 2001. Severe hypoglycemia increased by almost 5-folds in type 1 diabetes, and this is significantly, this increase is statistically significant. And when type 2, when we come to type 2, the increase in hypoglycemia during fasting, I'm comparing hypoglycemia in patients with type 2 diabetes and in type 1 diabetes. I'm not comparing type 1 to type 2. I'm comparing type 1 before Ramadan and during Ramadan, and type 2 before Ramadan and during Ramadan. So severe hypoglycemia increased 5-folds in type 1 and 7.5-fold in type 2 diabetes, and it is very statistically significant. That's compared to the condition before Ramadan, of course. The CREED study, which was published 2010 with more than 3,000 patients, hypoglycemic events recorded in 8.8% of patients type 2 diabetes. Prospective study in Pakistan with a number approaching 400 patients and published 2011, symptomatic hypoglycemia was observed in more than 1/3 of patients of type 1 and slightly less than 1/4 of the patients with type 2. That's for hypoglycemia. Hyperglycemia, again, is the second risk of glycemic events in Ramadan. EPDR study, which we mentioned before, severe hyperglycemia increased by more than 3-folds in type 1 and 5-folds in type 2. Again, this is not a comparison between type 2 and type 1. This is a comparison between before Ramadan and during Ramadan. And the study of Pakistan, there was asymptomatic hyperglycemia in 1/3 of patients type 1 and in 15% of type 2. DKA, this is the third glycemic risk which might happen to patients with diabetes who fast in Ramadan. Prospective study in the United Arab Emirates, it's a small study actually, published in 2014 with slightly less than 50 patients. Hospital admissions for DKA in Ramadan and Shawwal compared an average monthly admission rate were we're almost similar. Now, the key risks associated with Ramadan fasting in patients with diabetes, we have to remember, as I mentioned, hypoglycemia, which is by definition is below 70 milligram per deciliter. That's the increase of about 5-fold. Hyperglycemia increased by 3-fold in type 1 and 5-fold in type 2. And the diabetic ketoacidosis, in addition to dehydration and thrombosis. These are the risks, and these are the increase which happen in different types of patients, of diabetic patients. Summer fasting periods can last up to 20 hours. it's very long sometimes during the year. I mean, it's changeable, of course, according to the time of the year, but sometimes it can last to up to 20 hours per day and are often undertaken in hot and humid conditions like the Gulf states, or in hot and dry conditions like in Egypt and Sudan and Upper Egypt, I mean, and Sudan. Well, whole Egypt is hot, but in Upper Egypt it's much hotter, of course. Libya and all these places. So it depends on the place, but usually the weather is quite hot, and the daytime is quite prolonged. Education is an essential component of successful diabetes management. There is an evidence suggests that Ramadan-focused education programs can benefit patients in terms of glycemic control, weight loss, and reduction of hypoglycemia. And this is very strange, but it is very well documented actually, because usually when we better control glycemia, usually you are vulnerable to develop hypoglycemic attacks. But proper education can lead to better glycemic control and at the same time less attacks of hypoglycemia and better weight reduction. So that's the value of patient education regarding well, education of both patients and physicians is important. Both of them must be properly educated. They must have the risk. They must have know how to glucose monitor, do glucose monitoring. They must know about medications, of course. Even patients must know about the medication, the mode of action, and the risks. And nutrition is very important to prevent the risk of hypo and hyperglycemia, and exercise as well is very important. Treatment must be individualized for patients. I mean, one size does not fit all, like we always say. So individualization of treatment is very essential for patients with diabetes who choose to fast. Well, these are the component. I won't go through that. Time is running. It looks well. I shall stop actually when the time will finish, because it's a big and long issue, and definitely it needs a lot of time more than that. This is an example from the IDF DAR practical guidelines, and I'm just putting these two slides just to show the issue of risk stratification. When we speak about risk, we have to mention what level of risk is that. Is it very risky? Is it medium sort of risk, or just a mild risk? And according to that, the recommendation for the patient to fast or not to fast will be delivered according to the degree of risk, which we call risk stratification. Risk stratification is a very important part regarding if we discuss the issue of risk in Ramadan fasting. And when we speak about risk stratification, we have to focus, of course, on the degree of what will be exactly the possibility or the probability to develop a sort of complications. This is the implementation of the guidelines, and these are the factors contributing to Ramadan fasting risks. You can see here these two circles inside each other. The outer circle is Ramadan. In Ramadan, you can see the dark sleeping hours are more, And there are the two meals which are present in yellow here. And the inner circle represents outside Ramadan, where the sleeping hours are less, and there are 3 meals distributed all over the day. So physiological changes are most marked in countries at higher altitude with more daylight hours. Sleeping patterns are often altered during Ramadan. The impact of Ramadan on sleep includes decreased total sleep time, delayed sleep, decreased sleep period time, decreased sleep duration, and decreased proportion of deep sleep, increased proportion of non deep sleep. This is a shift. This is circadian rhythm. This is an important factor, actually, which sometimes are just missed. Shift of cortisol circadian rhythm has been observed during Ramadan. You can observe very clearly that in Ramadan, before Ramadan, you can see how the maximum secretion of of cortisol occur earlier than during Ramadan. And during the fasting hours, there is a progressive rise in hunger rating, which peaks up just before iftar time. You can compare on the right-hand side curve. You can see after Ramadan, you can see that the hunger peaks are almost flat. And in males and females here, you can see how it is exaggerated during Ramadan to reach a peak just before iftar. This is the homeostatic mechanisms in healthy individuals when they fast and when not. When they don't fast, there is food which will increase glucose level. This will stimulate secretion of insulin, and that will increase gluconeogenesis from the liver, increase blood coming out of the liver to the muscles, so that they can contract and do their work. And the reverse will happen if there is no food. If a healthy person will fast, definitely the secretion of insulin is less, and the gluconeogenesis is less, and the blood glucose will be less. But when that pathophysiology occurring in a diabetic patients, there will be increased gluconeogenesis, glycogenolysis, and ketogenesis in type 1 particularly, and that which will result in hypoglycemia, hyperglycemia, dehydration, thrombosis, and ketoacidosis. Well, these are my last. I stop after that because now my time is finished. So blood glucose levels remain stable during the day in healthy individuals. You can see that this is a fasting healthy individual. You can see it right in the middle of the curve, the iftar. There is a small peak which happened after iftar. If you can compare it with other patients, you can see that before iftar, blood glucose decreases. The glucose level was very stable in non-diabetic individuals before and after. But here you can see the exaggeration in the decrease of blood glucose before iftar, and the increase, the jump which will happen, the spike which will happen after iftar, usually in diabetic individuals. And these are the metabolic parameters. These are the changes in lipids. So let me end up with a summary of effects. Ramadan can affect meal schedules, sleep patterns, and circadian rhythm. Blood glucose levels remain stable during fasting in healthy individuals. Greater variability in blood glucose levels were observed in fasting patients with diabetes, and a sharp rise of blood glucose was recorded after iftar. For healthy individuals, favorable outcomes such as weight loss and lipid profile changes have been reported. Diabetes increases the risk of metabolic disturbances during Ramadan due to pathophysiology of glucose homeostasis. All patients with diabetes should seek medical advice before deciding to proceed with Ramadan fasting. I shall stop here for the sake of time. And again, I thank very much the organizers of this elegant conference. And I look forward to see you again and again. And كل عام وأنتم بخير. Ramadan is coming, approaching. جزاكم الله خيرا. السلام عليكم ورحمة الله وبركاته.